Welcome everyone to this online webinar hosted by the North and West Metropolitan Region Palliative Care Consortium on behalf of the Victorian Community Palliative Care Clinical Managers Forum. My name is Kathleen Menzies and I'm the manager of the North and West Metro Consortium. Before we begin, I'd like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners on the land on which all of our work takes place. I would like to pay my respects to their elders, past, present and emerging. I would also like to extend my respect to Aboriginal and Torres Strait Islander people who are on the call today. As many of us know, attracting and retaining a palliative care workforce can be a challenge. The purpose of this webinar is to provide an example of a very successful, innovative approach to support effective recruitment and retention of a palliative care workforce. Before we hear from our presenter, if you have any questions during the presentation, you can register your questions or add comments in the chat. At the end of the presentation, there will be an opportunity to ask those questions and I will get some more information if needed. Today, I have great pleasure to welcome Sarah Beckley from Eastern Palliative Care. Sarah is a clinical educator at EPC with over 12 years experience in community palliative care in metropolitan, regional and rural settings. She currently sits on the Committee of Palliative Care Nurses Australia. Sarah holds a Master's in Advanced Nursing Practice in Palliative Care from the University of Melbourne. Her passion lies in finding and fostering the next generations of palliative care professionals, which we'll hear about today, and supporting the advancement of palliative care in developing countries. Please join with me in welcoming Sarah to this webinar.
Hi everyone. My name is Sarah, and thank you very much, Kathleen, for that introduction. And I'd like to thank the Northwest Metropolitan Region Palliative Care Consortium for having me speak today and share the work that we've been doing at EPC. And what I love very much about this type of forum is that it's just so exciting to be able to share solutions that we've got to industry-wide problems. So, I hope today is a very useful presentation. So I might go to my slides if that's okay. So what I'm going to talk to you today is about a program we developed at Eastern Palliative Care called EPC Foundations. Now, I very cheekily called this a community palliative care boot camp because that's what I think it's a little bit like when you go off to the army and you do a intensive face-to-face boot camp to upskill you in in army warfare. But for palliative care, this is a community palliative care boot camp. And what I'm going to do today is talk to you a little bit about why this was needed, and then how we developed it, the challenges that we faced when we developed it, and then how we're measuring whether it's been useful and whether it met the aims that we originally set out to achieve. So next slide. So before I talk about the program, I wanted to share with you at the why. Why was this needed? So this is a picture of a screenshot of an article written by a friend of mine, and her name's Christine Hammond. And Christine and I started in community palliative care in Melbourne together about 12 or more years ago now. Now, when we started, Christine really was the picture of a nurse that was managing well. She always finished on time. She never seemed stressed, and she was very, very organised. And that was in contrast to me, who may have been the opposite of some of those things. But 2 years into our work at this community palliative care service, Christine stopped coming to work. She went on sick leave and then work cover and eventually resigned. And it was sometime later I met with Christine for coffee, and she told me that a psychologist had helped her figure out that she had what they call vicarious trauma. In other words, the things that she had been exposed to, the stressful things that she'd been exposed to on a daily basis in community palliative care, had had a huge impact on her mental health. And it meant that she needed to leave nursing altogether. And I met with Christine not long ago, and we wondered how her situation might have been different had she been set up properly. And she's just one story that reminds us of how important it is to start palliative care workers off with all the information and all the support they need. Next slide. So Christine was one example of why we needed to to do something differently. But EPC in itself had some signs that our nurses were struggling. So before the first course of EPC Foundations occurred, which was July 2023, I looked at the numbers of nurses that had started, and at EPC we'd had 67 new nurses start. And of those 67 new nurses, 91% hadn't worked in specialist palliative care before. So we'll go one more slide on. Yep. So for those that aren't working in community palliative care, the leap between uh, aged care or the hospital sector and community palliative care is huge. You go from being in an environment where you have backup and second opinions to an environment where you need to assess what's going on, diagnose what's going on, make a plan and interventions while deploying really nuanced communication skills with carers who really are oftentimes in the most stressful moments of their lives. And the weight of that is huge, especially when you start out. So I also looked at how many nurses we were keeping. And at EPC, of our 67 new nurses in those 5 years, 22 had left. So that's a 30%. 30% of our new nurses left EPC in those 5 years. So that was a big number for us. And then what I also discovered through an audit of medications before July 2023 was that these new nurses, carried with them quite a substantial degree of risk for the organisation. And what I mean by that is that when I audited our medication errors at EPC, 80% of our medication errors uh, in those 5 years had been made with nurses with less than 5 years experience. So not only did these nurses not have experience in the sector, but they were also quite a risk to the organisation. Next slide. I also, when I started this job, took a little bit of information and survey data from the new nurses who had less than 2 years experience at EPC. And what I found was that 70% of our new nurses at EPC felt that their orientation did not adequately prepare them for their roles. And 90% of them had little to no confidence in their management of opioids and on opioid conversions. So all of these things were yelling out to us that we needed to do something different. And I wonder, as I talk about these things, whether if you're a manager of a service, you think that these numbers are similar to what you are experiencing in your services too. Next slide. So without strong foundations for new nurses, what we were worried about at EPC was that there was low confidence, increased risk. The practice across EPC was very variable, and there was an increased turnover. Next slide. So what we created was a course called EPC Foundations, and it's a 10-day intensive training course. Now, the idea for this came from a manager, Chris Cliff, who's now left EPC, but he worked in the rural and remote sector, and they had similar retention and training issues and risk issues. So they addressed that issue by creating intensive courses. So we did that for community palliative care. So this intensive course is delivered over 2 to 3 weeks, and it's designed to fast track nurses and allied health from novices to advanced beginners. And I'm going to show you what I mean by that in a minute in the slides coming. We also had a comprehensive teaching staff. So it's facilitated by two EPC staff, and that is there's actually three of us. There's one nurse called Leanne Batty, and also Jenica Grays, and myself. We facilitate the education. But what we find is that actually EPC has a huge breadth of knowledge and expertise. So we bring in 22 other staff to share their knowledge and expertise. It's also interdisciplinary, and I'm going to talk a little bit more about that later. But the point I want to make there is that this is a course for allied health and nurses. The knowledge that we share and we use in community palliative care is the same. So the course is for everyone. Next slide. I'm just adjusting the light there. So the aims of this course was to increase the capacity and confidence of our new nurses and specialist palliative care workers, to reduce the risk associated with these nurses and allied health, to standardise the practice across EPC. And what we found really before the course started was that new staff did things the way they were showed when they shifts, and the way that was on those way they did it forever. So what we wanted to do was make sure that everyone was doing things like drawing up medications and syringe drivers in the same way. We wanted to improve our retention rate, and we wanted to develop a peer support network for new palliative care workers. Next slide. So before I go into the nitty-gritty of this course, what I want to do is I want to ask you questions. As I'm talking, I want everyone listening, anyone out there who's listening, to be thinking of these questions. To me, the biggest thing that's come out of this is that and I'm going to talk about it, it's been effective, and we want to share this resource. So my question is, thinking of your service, how can we best share this resource? One way is to provide this kind of the bones and the skeleton of what we've developed for other services to run. Now, the downside of that, EPC is very, very happy to do that. But the downside is it's hugely resource intensive to run, and you'll see why in a minute. If that's not an option, or we as a group decide no, or you think no, look, we don't have the resources or the educators to run this type of program, is it more economical for people to be sending their nurses to us? So, CAN's Community Palliative Care Service is sending 4 nurses down for the July course. So this is possible, and that is happening soon. So they're the questions we're going to revisit at the end of the presentation. Next slide. So how did I come up with this course? What I did was I used the Palliative Care Nurses Australia Competency Standard domains, and just as a guide to make sure that what I was putting in the course was guided in what, as an industry, we expect palliative care nurses and workers to be able to do. As the course was being developed, the Victorian Community Palliative Care Managers Network created a novice to expert framework, which was excellent because it was a bit of a cross check for me kind of enabled me to articulate what we were doing, which was moving our novices to advanced beginners. Next slide. So this is a bit of a plug and a this is an example of the novice to advanced practice trajectory for nurses in community specialist palliative care. And I just wanted to put that up here because I wanted to show you that what we are aiming to do is to move our nurses and our allied health from novices to advanced beginners. That's the aim of this course. Next slide. So, what's in there? Why is this course any different from any other course? So, I guess the first thing is I am a highly, if you can't already tell, I'm a highly interactive person. And so the course is very interactive, very pragmatic, and very practical and simulation based. So essentially we teach skills and then we get actors in to practice them. So for example, on the first day there we teach about de-escalation of anger. And then we get an actor to come in and pretend to be an angry patient so that we can practice those skills. And we do the same for every symptom that we teach. I'm going to talk about that in a few coming slides. Next slide. So, a cornerstone of the course is that we emphasize and teach very thorough assessment skills because really we can I think new staff get very worried about the medications and the management of symptoms. However, really what we wanted them to be able to do was to assess the symptoms well. So we give them really easy to remember frameworks to apply to pretty much every symptom that they assess, a verbal history and a physical history. And then once we've taught those and we go through every broad symptom in palliative care, then we get them to practice on each other and also on actors. Next slide. Really importantly to me, there's a big emphasis on, we make a very big emphasis on safety, conflict management, and reflective practice. And I think these are the elements that perhaps are missed oftentimes in palliative care training. But especially for community palliative care, it is so important. So we spend a lot of time talking about risk assessment and red flags and how to manage risk in a home. And then we also spend a lot of time talking about reflective practice to try and help the new palliative care workers develop skills to um, to be able to be self-aware and to reflect. So we spend a whole day on that topic. We go back now. Yep. So to address the risk associated with these nurses, we teach and reteach important clinical skills, such as drawing up medications, developing and writing support medication forms and orders, and doing syringe drivers. And these are skills that we demonstrate, and then we get them to practice and practice and practice until we're really confident that they are doing them safely. Next slide. Probably the most important part of the course to me is really solid foundations in end of life care teaching and end of life care education. And what I mean by that is that we spend a whole day talking about end of life care and death and dying, and I make the two most important parts, that messages I try to get across in those days, are that this moment, that the end of life, the visit to a home where someone is dying, really is profoundly important for that family, and that moment in time for that family is really, really important. So I try to get across, for loss of better words, the sacredness of what we do when we visit someone who is dying at home. And then we go through how to teach families what to do when their loved one is dying at home, because I think oftentimes healthcare workers can get very good at explaining things but with jargon, and can presume a lot of things, but oftentimes everything is new to families. And so we spend a lot of time practicing how to teach everything in an end-of-life care home visit. So that to me is, you can probably tell, that's my favourite day of the whole course. Next slide. So I previously had pictures of the program, but it really that's just too wordy and doesn't look good. So I've just put kind of an example of the breadth of topics that we cover in those 10 days. And as you can see, it's huge. We go through all the symptoms, we do a lot of safety, we do lots of psychosocial and psychosocial aspects of care and palliative care. We talk about pediatrics and M&D. We talk about tricky conversations. We get the Centre for Palliative Care to come in and help us teach communication skills, and that's a really very valuable workshop. And then we spend a day talking about kind of the nitty gritty but boring stuff, but really important stuff like note writing, PAL care, care planning, handover, communication in teams. So it's hugely comprehensive. The other aspect of the course that's really important is that we have 2 days at the end of each of the weeks, where we have simulated home visits. So we have this amazing group of EPC volunteers that come in and pretend to be patients, and we set them up in little tiny rooms around EPC, and there's an observer in the room. And the nurses and allied health, it's kind of a little bit like Thank God You're Here. They knock on the door and they do a pretend home visit. And then they have feedback about that pretend home visit. And essentially it's about having a go and using what we've taught them and having a practice. Next slide. So, who's done the course so far? We've had 3 courses and we've had 26 participants. The first 2 courses had EPC staff members only, and that was 21 EPC staff members. And then the last course in March was we had external participants, because really we've trained most of our new staff members at EPC. And so we had three nurses come from rural Victoria and a rural educator as well. And then we also had 2 nurses come from a private community palliative care service in Melbourne. Everyone who's done the course has had less than 1 year experience in community palliative care. Next slide. So the biggest question to me really was, how are we going to be sure that this was delivering what we needed? And there's just no point putting together this hugely expensive course with so many resources if we can't be sure that it was delivering what we needed. So I've tried very hard. I'm no researcher, and if anyone wants to do a PhD on this, I'd love that. But we tried take different approaches to measuring the impact. So we had subjective measures, which is pre and post confidence surveys. And I'll talk about these results in a second. We took objective measurements and assessments, which were observational assessments. And then we've looked at the organisational impact. So I'm going to go through what these results look like for EPC and why it's been so impactful. Next slide. So organisationally, this has been really profound for EPC. We went from 30% of our nurses leaving over those 5 years to a nurse turnover of 5%. So of the 21 people who've done the course, the EPC staff members, only 1 has left. And I actually recently did a survey of the people who did the course in July, and they are still thriving and still feeling really confident and want to stay in community palliative care for their careers. So it really had quite profound impact on our nurse retention, and we really have, as I said, nearly trained all of our novice community palliative care workers. Next slide. So subjectively, the there's all these pretty graphs, but no one really wants to see the graphs. But what I can tell you is that the pre and post, we measure the participants' confidence before the course and after the course in certain skills. And what it showed was that it really profoundly impacted their confidence, and it increased their confidence in symptom management, end of life care, and carer education, increased awareness of reflective practice, and increased confidence in their communication skills. And really, I think these things combined, we are really setting nurses up to feel good coming to work and feeling safe because they feel confident. Next slide. So I mentioned the objective measurements, that the course was doing well. And what I mean by that is, we did, as I said, we did we do simulations, and we have actors in a room and they do pretend home visits. And we take observational assessments of the learners when they do those simulated home visits. And what I've provided on the slide there is an example. We created an observational assessment tool, and this is an example of the things that we are looking for uh, in these observational assessments. And what we found was that nurses, and you can see there, the next column along, it says March 2024 pre, was that the participants started not really having a huge grasp on these home visits, and not really meeting a lot of these key points of a home visit. But then after the course and the last observational assessment, they really were nailing it. And the reason we needed to do these observational assessments, because really the question was, what do we want these nurses to come, and allied health, to come out of the course with? And the answer was, we wanted them to be able to do a holistic home visit. So that's why we measured it, took the objective measures as observational assessments. Next slide. So the big question is this worth the investment in time and money for other services? And I imagine if you are a manager sitting at a service maybe across Australia, you are thinking to yourself, how much does it cost, and is it worth it? And so the first answer to that question is, to an external participant to do the course, is $3,100. And I can answer that question by saying a big emphatic yes, it is. And I'm going to show you why it's worth the time and money. Next slide. So, as I said, to do the course costs $3,100, but the economics of new nurses at EPC are quite substantial. And I wonder if these numbers are similar for your services. So to have a new nurse at EPC, to recruit them, onboard them, orientate them, to train them with supernumerary time, costs a total of $5,694 per nurse. Now, EPC were you doing that using having those costs quite frequently, because we were losing nurses. But since this course, we have lost one nurse, which is pretty amazing. So this cost has reduced significantly since we have started the course. Next slide. Organisationally, I think it's more than just nurses costing us money, new nurses. It's if a nurse isn't set up well, as we said, there's increased risk. There's decreased quality, potentially decreased quality of care, because we don't necessarily know that the nurses are doing things safely, because they've only had 1 or 2 days to be shown certain tasks. They've got lower confidence, and they potentially have lower foundational clinical skills. There's organisations also have increased turnover and costs associated with staff loss. So the impact of not setting our nurses up well for organisations is quite substantial. Next slide. So how did we do? if we go back to those aims that I shared at the start, we really did. This course has substantially increased the confidence of our nurses and allied health. And as I said, we've even looked at this long term now, a year on, and it's still having an impact. We've reduced risk in our organisation, and our quality and safety manager at EPC says that she feels that there's an increased reporting of errors by new staff, and also what's coming through in our risk register is that new staff feel empowered to be able to respond to things like conflict and anger in a home. I've found, and the feedback I've got, is that our new staff are really the gold standard of practice at EPC, and that is, that they've been taught how to do care plans well, how to write notes well, and how to draw up medications and action plans. So they are doing really well. As I said, we've improved retention, and actually, I've said that's 100%, but that one nurse only recently left, so that's actually just a little bit less. I think it's 95 now, but it's substantially turned around our retention rate. And in fact, really, EPC, as I said, have trained most of our new staff, and we're now looking to offer this to other organisations. Probably one of the most exciting parts of this course for me was that every time we run it, it develops organically this little network of peers, of staff and colleagues at the same level. And, that's been really beautiful to watch. Each course has a WhatsApp group and they stay really beautifully connected. Next slide. So, Kathleen asked me to talk about the challenges in setting this up. So, there's kind of personal, smaller challenges, and then there's wider challenges, more macro. So, the smaller challenges for me were around, firstly, was just about the resources and time to set this up, and it was really monumentally big. But I wouldn't take it back for the world, because it's come out and it's really done what we wanted to achieve. I think one of the challenges is, and in implementing this, was around change management and convincing EPC managers that this course, so having staff members off the road for 2 to 3 weeks, is absolutely worth the brief reduction in service capacity. And that's a really hard thing to swallow for new managers, but it was interesting after the first course how that movement really changed. They could see the difference in their new staff members, and now that we don't have any trouble getting staff members on the course. I also, one of the things I learned was that I work with a huge range of highly competent and skilled people, and I just presume that everyone likes to teach. But I was amazed at how many staff members really don't like teaching. So I had to convince a lot of my colleagues that they could teach. I think one of the learnings as a person who hasn't trained as a teacher is how to engage a disengaged learner. It was a really big learning for me, and also making sure that the course doesn't replace performance management. We can't just have people on it who aren't doing well. That's not the idea at all. Next slide. More broadly speaking, now that we are thinking about and offering this externally, what we are the biggest challenge I think that we face is that it is expensive. $3,100 is quite expensive, and so convincing services that it's worth the investment is the challenge. I think too, what I would love to see with this course is that this is seen as a shared resource, and that services, even bigger services who have their own clinical educators, can use their resources elsewhere and send their novice workers to us to do this, because we've got it set up. One of the challenges I found is, and I'm still working on it, is how to teach reading the room. That's a core skill for a community palliative care worker, walking in and reading the social cues, reading the patient and their families. Teaching that and learning how to teach that is and continues to be a challenge. And really, what we found after this is that because no one's leaving EPC, we then need to to really be choosy about who we have. So that's been in itself an interesting challenge that's arisen as the course has gone on. Next slide. So I'm getting to the end now. So the learnings, as I probably have kind of demonstrated, have been pretty profound. And I guess the biggest one is that starting new staff off feeling valued and confident is an absolute joy. And it has been so lovely to see a whole cohort of nurses and allied health feel uh, confident and happy as they start. Uh, as I said, the resources in putting this together were profound, and but I think the investment in time and the time and money for these new staff was absolutely worth it. I guess too, I'm very grateful for my manager Maria Logan and my previous manager Chris Cliff, who really had a lot of faith in me, and they didn't really give me any limits. So it just shows that there's no stopping what you can put together if you're trusted and given the room to really innovate. And I also learnt that learning intentions are really important, because if you don't know where you're going at the start, then it's very hard to guide what happens after. Next slide. Nearly there. So the future directions of the course, we've got 3 courses booked for 2024 and 4 courses booked in 2025. The next course is in July, and that's fully booked out now. And as I said, we've got 4 people coming from Cairns to do that. And then we've also got facilitators, so educators coming from rural services, to come and watch and learn and participate, so that they can be part of the conversation, um, and tell us how this might look for them in the future, if at all. One thing I'm working on at the moment with a wonderful colleague, Nancy Stephen, who's helped me develop a lot of the learning and teaching aspects of this course, is obtaining recognition of prior learning. So partnering with a university so that learners, this contributes to part of a certificate in palliative care, so that's really exciting. So last slide. So we come back to this question. There's a question for you, and we don't necessarily need to answer it now. But so again, these questions: how do we best share this? We've trained our staff members, but we really want this to be something that is used Australia wide, if that's something that could be done. But how would that look? So look, thank you very much for having me, and I really look forward to the discussion now. So please ask questions.
Wow, what a fantastic presentation, Sarah. I'm inspired. And if I wasn't as old as I am, I'd probably come and do the course. So
Good.
thank you. Thank you. And what's beautiful about it is it's evidence-based, and you've actually developed it, as you said, based on learning outcomes and being clear about what you wanted to achieve with the group. So there has a couple of questions have come out. So first of all, somebody's asked about the possibility of structuring the course for inpatient nurses, which I think is a good question. And is there, using your model, is there a way in which that sort of inpatient slant or approach could be considered? What you thinking about that?
Oh, absolutely. So I think the course is very relevant to inpatients, to nurses who and allied health who are in an inpatient setting. Uh, and I think if we they so we actually had a rural nurse come from a rural hospital who was in an inpatient setting, and she came and did the course last time. And what we found is that some things needed to be altered, but on the whole, really it was very relevant to her. And some of the aspects are different in the hospital. You have a bit more backup, but really at its core, we still want our nurses and allied health to assess skills well. We still want them to be able to uh, de-escalate anger and identify risks. So really, it would be something that would be very doable, and perhaps would be something that we could make a little bit smaller for an inpatient setting.
And indeed, you could probably join it up with community. So, as the individual who asked this question said, you could have some days devoted particularly to community, some to an inpatient setting, and the nurse could become skilled in both to some extent.
Yeah, look, and I think so. The first day of the course is about risk, uh, and management of risk and reflective practice. And while they're particularly important skills in the community, I think they're important skills in the inpatient setting too. So it would be a conversation. It was absolutely relevant to inpatient nurses and allied health, and it would just be a matter of how what we take out. That would be a challenge because I think actually all of it's relevant to everyone.
Indeed, indeed. Um, there's a question about whether or not EPC is committed to hosting this course beyond 2025.
That's a good question. And I
Yeah.
don't know the answer to that actually. I think EPC as an organisation, I think feel very very committed and invested in this course, but actually we haven't discussed where it's going to from here. And I guess we have committed to 2025, but I guess the question is there appetite? It has to be something that's being used for EPC to commit to it that long term. Good question, though.
Indeed. Yeah. Another thing that's sort of come to mind is you've said this course is for both nurses and for allied health. And tell us a little bit more about how that works, given that they're very discrete skill sets,
Yeah,
sort of.
absolutely. So, yeah, look, it's been that in itself that has been a very interesting process to and so originally the course was designed for nurses, community palliative care nurses, and in the first course we had an allied health uh, a family support worker who's a psychologist and a social worker come and do the course. And she was very experienced, and her brief was to look at every session and review it and tell us whether it's relevant or not relevant to new allied health workers. And I kind of half expected her to say, "Nah, it's not relevant." But it, bar one day of content, she said everything was relevant, and it was that in itself for me was quite a moment, quite interesting because it just shows that what we share in the community in this setting where you it's kind of blurry lines like that. So, and at Allied, our FSWs really wanted to know about pain management. They didn't need to manage it, but they wanted to know about it so they could answer questions. The next course we had three. Because of that, we had three family support workers, so social workers, come and do the course. And what we found, and when they did the course, we had a special half day dedicated to their content. So, like a psychosocial spiritual assessment, and other complex psychosocial care uh, lessons. But what we found was that was relevant to nurses too. So in the end, we've put everything together, and just in the acknowledgement that what we do in community palliative care is very shared. So yeah, that's been a beautiful part. So it's very much for everyone.
Excellent, excellent. And that's a great learning, isn't it? About how the multidisciplinary team is indeed a multidisciplinary team caring for an individual. Yeah,
Yeah, absolutely.
yeah, true. I'm really interested in the idea of when somebody starts this course. And you mentioned they were um, under 1 year employment or, in palliative care. That was the sort of recommendation. So in their first year of palliative care. Um, I'm just wondering how you may undo practices that they've learned in the first year. If I mean that gently and with respect. So practices that aren't quite as good or not quite right, because
That's a
I'm
good
sure it
question.
happens.
Yeah, I think the lovely thing about having adults come and learn is that they come, and nurses and allied health, you come with a whole life and career of experiences. And I think that part of how we teach this course is it's very interactive and we learn from each other. So I think as the course evolves, it's sometimes it's quite obvious that there are different practices out there, and I think it's just a matter of conversations. And someone might say, well, I don't do that, and we'll go, and then there'll be a conversation about, well, we do this way at EPC and this is why, and then there might be a bit more of a conversation. um, so, and look, it was lovely. We had uh, EPC staff members come and do it who'd been at EPC for a year, and practical stuff like drawing up breakthrough medications. We demonstrate that and then we teach them. And it was amazing how many of them were floored by the fact by the demonstration that we were showing them. So I guess we teach some of the bad habits. It's not bad habits, just what you were showing, but we teach it. We try to cover that by making sure that we demonstrate all the skills that we'd like and how we'd like them to be, how we'd like staff to do the certain things. Does that answer that
And
question?
I suppose, yeah, and I suppose it's framing things as best practice, isn't it?
Yeah.
Standardized practice, best practice.
But it's
But
a
also, as you
conversation
said,
though. Yeah, yeah.
mm,
It really, it's a, I guess, our style. We are adult learners, and they are all clinicians who've come with their own experience, and it's a very, very respectful kind of toing and froing of experience and what's worked and what hasn't worked and what is best practice. Yeah,
yeah,
and
yeah,
that's what makes it such an interesting course because it's so conversational.
yeah. So, are there any advocacy groups or government funding opportunities that might be interested in scholarships or being able to fund this course
Oh,
that you are aware of?
so if there is someone who is listening who is a expert in exactly that, please call me because I would love to. That's the big question, right? I guess that's the question for the industry too, isn't it? But for example, the Cairns Community Palliative Care Service have tapped into funding from the government, and I'm not exactly sure what type of funding that was, but there was government funding uh, to, I think, workforce related, palliative care workforce related funding to fund sending their staff members down to Melbourne for those 3 weeks to do the course. And that's the big question, isn't it? Because really, money doesn't grow on trees, and every service is struggling with money. So where does this come from? And I really feel that if anyone has great ideas about which government department we ask to help us with this to make it doable for other services to come and do it, that would be. But no, I don't have any great ideas about that.
Well,
It's a
you
good
never
question
know.
though.
There might be some organisations who are willing to provide scholarships or put them out there because it sounds like it's such a fantastic opportunity. Now, I'm
Yep.
going to play the devil's advocate and identify Mary Lou, who's been sent to your course because the organisation is worried that her practice is really not up to scratch, and so is using EPC's course as a panacea to, sort of fix
Mhm.
that problem. Do you do any, two questions, do you do any screening of, people
Mm.
who've applied to be part of the course, both of the applicant and the organisation, why the person's doing the course? And how do you tackle that? Because it could be a bit tricky.
Oh yeah, absolutely. So it's something that we've had to learn, because absolutely we had a few staff members who came on the course who probably needed to have conversations around their performance but didn't get told that they were not doing so well, and then they were on the course, and that doesn't work. So to counter that, because it's all learning, these things, it's evolving as it goes on. But what I've learned is that we call the participants before they do the course, and we talk about their learning, why they're doing the course, why do they want to do the course. We get them. We get them to ask. We ask them about their learning needs, but then we also get them to sign a learning contract, which outlines, the expectations. And part of the expectations of the course, because of exactly the thing that you've just described, is frequent check-ins with the facilitators. So at different time points, probably 2 or 3 usually, the facilitators, being myself and Jenica Grays or Leanne Batty, will check in with the participants and, give them feedback if they need it. One participant we had last time was really struggling with the simulations. She hated the simulations, and we were able to give that feedback for them to grow. At EPC particularly, if we've had staff members that are struggling with learning, now what we do is they can't come on the course unless they're being told and they've got a plan and they know what they need to focus on. But we don't have that process yet for external participants, but I think that's probably coming.
Excellent. So it sounds like you're using what's learned throughout this whole process and filling it back into the way the course is actually implemented over time. So in light of that, you've conducted 3 courses now, or four?
Three,
Um,
three. No, four,
3,
four, four.
4.
Three.
Okay. And July will be 4. So have you actually changed any of the, excuse me, that was my phone, I'll just ignore that. Have you changed any of your program or content as a consequence
Mm.
of the uh, feedback or
Oh,
the
absolutely.
process of delivering?
We absolutely. It's been a beautiful process in learning how things evolve and change. It doesn't need to be perfect at the start. It just keeps evolving. And what we do during the course is every day we get feedback from the learners about the content, and at the end as well. But good examples of how things have changed. So at the start, when I put it together, what I really thought was needed in a course like this was lots of on the road time with nurses. And so the first course had 6 supernumerary buddy days with nurses at EPC. But what we found was that the learning value of that was a bit dubious, and it really depended on the nurse that they went out with on that day, and and so we found the feedback from the learners was that actually it wasn't that valuable. So we got rid of those 6 buddy nurse days and replace them with full days of simulation, because that really was what the learners felt was most valuable in terms of their learning and practicing the skills that they've been taught. And yeah, and look, in terms of content, we initially, when we started, I had a whole bunch of content that was probably more onboarding than it was specific community palliative care content. And so we got rid of that. And in the last course, when we had external participants, we had some EPC specific content in there. So this course, we've moved all of that EPC specific content onto a time when the external participants aren't there. So yeah, it's ever evolving, and I imagine in a year's time it'll look a bit different again, because we're getting feedback and it's growing.
That's fantastic. That's so good. So it sort of sounds like you've got a longer term vision in terms of making sure the course is a dynamic one, fits in
Hmm.
with the practice changes and evolution in terms of palliative care and how it's being delivered. So I've got a comment from the floor. It says the course is beautifully set up to put participants at ease to discuss everything. That's a great comment. And
Thank
then
you.
there's another, yeah, and another comment. You've got another a fan here. I'm a long time fan of this course. Amazing work, Sarah. I think the Palliative Care Consortia would be eager to help with the promotion and advocacy, and perhaps even a briefing paper for our member organisations. So I'm not quite sure who sent
Yes.
that in, but obviously we've certainly got
That
some
person I
fans
planted
in
in
the
there.
room.
No, I didn't. I
Yep.
didn't.
Oh, Adam,
Yeah.
Adam. See?
Oh, thanks,
So
Adam.
Adam up
Adam.
from Loddon Mallee.
So look, Adam,
Yep.
I give
So
Adam a shout out because Adam was the person who who compared it to a boot camp, and I've been using that analogy ever since. So thanks, Adam.
Okay, so thank you, Adam. That's great feedback. I'm assuming there's no other feedback from the floor. I'd just like to say thank you to everyone who has attended this webinar, and we're really looking forward to getting your feedback. So there'll be a QR code that goes up on the screen. Can I send out a very, very special thank you to Sarah on the work that she's done in preparing for this presentation? And I really do appreciate the effort that has been put in today. We would hope to be able to support further webinars on recruitment, retention and succession planning. So if your organisation has doing any innovation in that space, can you please let me know, and we'll see what we can do to support you to prepare a webinar like this that we can send out across the state. We will post this particular webinar as a YouTube on our website, and we'll also circulate it to those people who've actually attended today. Another fabulous comment: fabulous and visionary program in the Gippsland region. The Integrated Cancer Services, the EICS, does provide scholarships, may be an option. There you go. So we've got people in the room already thinking about how we can actually spread this more widely. So thank you again to everyone for attending. Check out our YouTube site. We'll make sure we send you the link to the recording. Stay safe out there. Have a wonderful long weekend and enjoy this chilly weather.